Good morning. Welcome, everyone. It's my pleasure to introduce Dr. Harmeet Gill, who is been a longtime friend in our residency program and always helpful when I call upon him to give rounds. I think his topic this morning is fantastic for all of us, especially the general ophthalmologists and the residents who take call. So he's a double board certified oculofacial plastic surgeon. He did his residency here in Toronto and his fellowship at University of California, San Francisco. He is, as we know, committed to providing exceptional natural results, and he customizes his work to the needs of each patient. And he's quite unique in that he specializes in ophthalmology, eye surgery, as well as facial plastic surgery. He is a fantastic teacher of the residents. I've seen him work, and they love what he does for us here. What you may not know about Harmeet, even though we all know he's fantastic at his work, is that he's someone you want with you in a dark alley because he's an accomplished martial artist. I did not know this about you, Harmeet, and I'll be careful not to annoy you. Maybe I'll give you a buy on rounds for a couple of years, or you'll beat me up because you're a first Dan black belt in Shotokan karate. So welcome, everybody, Dr. Gill.
Oh, thanks, John. Wow, what an intro. It's a pleasure being here and wonderful, connecting virtually, and I appreciate the department inviting me. So we'll get right to it. So, one of the big things that I get called about from friends and colleagues in the community, and certainly even some of the docs at Sunnybrook, is, specifics about eyelid and orbital trauma. So we're going to dive deep with that, and we have some great resident presentations coming up. And we can go to the next slide. So the objectives are, by the end of this presentation, that we have an understanding of the important anatomical considerations, like how do you categorize different types of eyelid trauma? What are the questions you want to ask yourself and the other doctors involved in the care of this patient? The second objective is to be able to repair basic eyelid lacerations. I've heard from some docs in different scenarios where they're in a bit of a panic, where they don't really feel comfortable repairing an eyelid laceration. And sometimes you just can't access oculoplastics as quickly as you'd like. And general plastics in some hospitals may not feel comfortable doing the laceration. So we want to give you at least a basic approach to stabilize an eyelid laceration and go over the specifics of that. And finally, we're going to give an overview on how to triage orbitofacial trauma, more like in a medical legal perspective, like what are the basics that are expected of an ophthalmologist and what are the important things you should do. So from here, we're going to get Ali Cote to dive deep within the eyelid talk, and then we'll do the orbital talk with Safwan after that.
Okay, good morning. Can everyone hear me and see my screen okay?
Yeah, perfect.
Perfect. So I'm Ellie, I'm one of the PGY3 residents, and just wanted to take the opportunity to thank Dr. Gill and the department for the opportunity to present and hopefully show you guys some interesting cases. So let's jump right into it. So for some reason, these things always seem to happen on a Friday night, but imagine yourself in one of these scenarios when you get called on a Friday from Emerge at your hospital, and they tell you you have an eyelid laceration. Now, before you start panicking, wondering what to do, maybe, it's important to take a second to sit down, think about your approach, and maybe think about what kind of information you want to get, even from the emergency doctor, before you head into the hospital. So important things to kind of help you to think about these traumas is, one, what's the mechanism and severity of the trauma? You really want to be on the lookout for, is there going to be some more serious injury here, or is it really just confined to the eyelid? Is the emergency doctor able to at least visualize the globe, again, to give you a sense of how severe the trauma is? Are they able to get a vision on the patient? And lastly, has any CT scan been performed of the orbits and facial bones? Because it's not uncommon when people have trauma to the eyelids or orbital area that there might be some underlying fractures as well. So these are kind of just some things you want to think about before you're even heading in to see the patient, just so you kind of know what you're heading into. Now, once you get there, a few just considerations about the examination. First thing, of course, and obvious, but you want to make sure there's no life-threatening injuries there. Make sure there's nothing subtle that you're missing or that the Emerge doc missed, and that you're really being comprehensive. And then after that, once you figure out the patient's okay, make sure that there's no vision-threatening injuries. So really make sure you do a good globe exam, a good fundus exam, and make sure that the eye itself is okay. And then kind of once you've made sure that all those things are stable and okay, then you can really focus on the eyelid and try to take a nice anatomical approach to the eyelid repair to get the patient the best results you can. So let's just go over a few quick cases here. I'm just going to present a few cases to show kind of the variety of different eyelid lacerations you can get, and then we'll delve a bit deeper into their kind of repair. So case one, so this is a young 21-year-old female who was punched in the face. And again, running through kind of our previous slide there, so no life-threatening injuries, her globe was completely intact, and her eye and exam was otherwise normal. Moving on to another case here. So this is a 23-year-old female who kind of fell face first off of a snowmobile. And again, you can see that there might be a little piece of eyelid here. Something doesn't quite look right there. But luckily for her, her globe was intact. And again, her exam was otherwise normal. And case number 3 here, this is a 21-year-old female who was assaulted as well. And just something to note here, the laceration is quite medial, so that'll just kind of have a few implications when we discuss a bit more later. But again, the globe here is intact and the exam is otherwise normal. So we'll delve a bit more into the specifics of these lacerations and how to repair them, but just wanted to give everyone a sense of kind of the variety of different eyelid lacerations that can happen here. So you're in Emerge, you're seeing the patient and you're wondering, how do I repair this laceration? What are the goals when I'm doing this? So of course, the first thing you want to do is try your best to restore the normal anatomy there. These can be tricky sometimes depending on the laceration, if it's straight, if it's kind of jagged or the mechanism of trauma. And then once you're able to restore normal anatomy, you want to try your best for the eyelid to retain its natural function, so the patient's not going to have terrible tearing or dry eyes or be too symptomatic afterwards. And then lastly, if possible, trying to optimize the aesthetic results, just because the eyelids are a tissue that everyone kind of sees on a day-to-day basis. So it's nice if you can try to make it look nice as well. Now, a few busy slides here, just with some anatomy. Not going to delve, deep into the specifics here, but again, just to give everyone a sense of kind of the tissues that you're dealing with, especially in these eyelid cases. And you can see with the eyelid anatomy, if you have a laceration closer to the margin or just above it, then you'll be dealing likely with some tarsal tissue as well. And if you're a bit higher than that, then you might be getting into septum, fat, or levator. So all things to just kind of consider and keep in mind when you're examining and seeing these patients.
And Ellie, I'll just jump in for 1 sec. I think as a general category, when you're thinking about an eyelid laceration anatomically, you want to think about if you're close to the margin, and if you are, then you separate it into anterior and posterior lamellar involvement. That'll affect the sutures you use and how you approach it. And if it's a little further from the margin, then you just want to think, are you preseptal or postseptal? Because that'll also affect management, which we'll get into a little later. So that's like in a broad way. If you're starting to see orbital fat, that means you're postseptal. If you're not seeing orbital fat, that means you're probably preseptal. And that's really important if you're worried about a foreign body as well.
Perfect, thank you. So lower lid, again, essentially the same thing applies. Just note that the tarsus is smaller on the lower eyelid there. And then when we're looking specifically at the eyelid margin, this is especially important when patients have, of course, eyelid margin involving lacerations, because you really want to make sure that you can reapproximate that tissue well. And things to keep in mind are the meibomian gland orifices and the lash line as well, because we'll often place the sutures kind of along these areas to try to reapproximate the margin as best we can. And again, we'll kind of delve a bit more into that later. Now, if you have a laceration that's a bit more medial, you always want to worry about the lacrimal system being involved. So just a very basic overview of some of the anatomy here. So just remember we have the two puncta that kind of delve down and upwards for about 2 millimeters. And then the canaliculi run horizontally for about 8 millimeters. And in most, but not everyone, they form into a common canaliculus just before getting into the lacrimal sac here medially. So just keeping in mind that any medial lacerations there, you want to keep a high suspicion for canalicular involvement. And then the last thing in terms of anatomy is just to think about, again, the canthal tendons. So if the cuts are quite medial or quite lateral and the canthal tendons are involved, those are kind of structures that you want to try to include in your repair if possible, just to kind of optimize the result in eyelid positioning for the patient. So now that we have kind of a basic overview of the anatomy, let's go into some considerations when you're assessing these patients. So as Dr. Gill mentioned, one of the things we want to think about is there fat prolapse from the wound? Another thing is the lid margin involved? Furthermore, is the lacrimal system involved, and is the canthal tendon involved? So kind of all things based on the anatomy we were just looking at. And now let's kind of have a look at some cases related to all of these and how we approach them. So if we jump back to our first case here, although this laceration is quite medial, when you probe the canalicular system, it's completely intact. And I know that it looks like this laceration extends downward here, but it actually does not involve a margin. It stops right before. So in this case, there's no fat prolapse. The eyelid margin is not involved, the lacrimal system is not involved, and the canthal tendons are not involved. So this is actually, even though it looks like it's in a scary location, is really just a simple laceration of the skin here. So at this point, I'll just hand it over to Dr. Gill to discuss some kind of high yield topics for repairing these simple kinds of lacerations, starting just with the basic equipment that you would need for these cases.
Perfect. Ellie, if you could just go back to your consideration slide. So I think this is a really important slide and one big take home message, and it's just an approach. So if, whenever you get called about a laceration, if you just ask yourself these 4 questions, it'll really help in terms of managing it, knowing what you can handle, and then how to triage it when you're communicating with oculoplastic. So again, fat prolapse, yes or no, lid margin, yes or no, lacrimal system. And if you can't assess it, it's too much swelling, you can just say lacrimal system could not be tested. Ideally, if you can test it, it helps triage better. And then the canthal tendon being involved, if it is, it tells you that there's a higher chance of an orbitofacial fracture, and then tells you really do need to get a CT scan if you think the tendon's also involved. Okay, Ellie, so we can go up to the next slide there. So what do you need? So again, another slide, if you want to just have it in your phone, take a picture of this one. If you get called and you need to go in and repair it, these are the basics. So you tell the nursing staff in the ER or in the eye treatment room, wherever your hospital is, that you need a lidocaine 2% with epinephrine. Epinephrine's better, it helps with hemostasis. If you try to repair these without hemostasis, it's much more difficult. 3 cc syringe is easier to inject with, and a 30 gauge needle, less painful for patients. You'd need a forceps, a needle driver, and Westcott scissors, cautery for hemostasis, which could just be a handheld thermal cautery or a bipolar, sterile gauze, and drapes, of course. If there's any risk of a foreign body, bacitracin is absolutely necessary, because the last thing you want is to trap, foreign material or bacteria in a wound that you've closed. You'll cause more problems. And if you have the option of just getting bacitracin irrigation, the nurses can just mix it up for you in a ½ liter of saline. It's much better to irrigate the wound. And it's interesting with some trauma patients, once you irrigate with bacitracin, you can almost see the tissues thanking you, like things start to settle down and your repair will be a little bit easier. If they ask, cold water is better, because cold water does kind of cause a little bit of vasoconstriction, so the tissues will bleed less. In terms of sutures, really the only 3 sutures you'd need are 5/0 silk, 6/0 plain, and 5/0 vicryl. I'd avoid using permanent sutures like Prolene or nylon close to the eyes, because they can poke the cornea and cause other problems. So silk is very soft and very high tensile strength. So we can go to the next slide. And here are some nice pictures that Ellie found. Just again, if you want to just take a picture with your phone and just have it for those emergency days when you may need to kind of make sure you have all these things available. And you can go to the next slide. And again, we're all familiar with this basic equipment, and that's the bacitracin irrigation. With the thermal cautery, you do have to be careful. They get very hot, as we all know. So when you're working near the eye, certainly have to be careful. And next slide.
What's the ratio for the bacitracin? Do you put that entire vial in a certain amount of sterile water?
Yeah, my go-to, John, is to just put it in a half a liter of saline. If they say, oh, we don't have saline, we have Ringer's lactate, whatever, it doesn't matter because it's just for irrigation. But if it's cold, and about a half a liter would be enough, it would be a good concentration to use. And then with these sutures, one of the things I'll mention is you'll see that all of these sutures, if you look in the middle, there's like a triangle there. You see that how that triangle is facing downwards? So it's called a base up triangle. So if you do think about this, like if you can get a suture with a base up triangle as the needle, it's easier to handle tissue. If it's a base down triangle, you may start cutting through this, so it's harder to handle tissue. So if you have the option, always try to get a needle with a base up triangle, not a base down triangle, and that's better because the sharp end is at the bottom, so you can actually pass your suture through the skin without it kind of cutting through. Yep. So we'll go to the next slide. In general, with simple lacerations, you always want to freshen the wound edges. Usually we see these patients, 1, 2, 5, 10, 12 hours after the original trauma. You don't want to suture devitalized tissue. Usually just like a little bit of devitalization where the tissue starts to bleed again. So someone may ask, okay, should I take half a millimeter? Should I take like more? Basically, once you've gotten the wound edges to bleed, that's good. And then, it's kind of ironic where you may cause them to bleed and then cauterize again. But typically, I try to just devitalize till the edges are bleeding, and then you try to get them suture those together. You don't want too much tension on your wounds. So if the patient's very, very swollen, you might even defer your closure for maybe 10 hours or so, depending on the scenario. Again, handheld thermal cautery is great. I would recommend using interrupted sutures when you're dealing with lacerations, unless it's very big, because the sutures may break. Like if you had a running suture and then the patient continued to swell, it could break, and that way, your whole closure could open up. So I think interrupted sutures tend to be better. And we do like to, in terms of just an approach, you'll remember from basic suturing that you always want to divide wounds in half as you're taking tension off an open wound. But in terms of, periocular trauma, we do like to get the apices centered so that your tissue alignment is good. So we'll go to the next slide, Ali. And so here's an example, like you have a laceration there, so you want to get that apex closed. And as this diagram illustrates, interrupted sutures are better than a running. Interrupted sutures are also good because if you think about the orbicularis oculi, it's a circular muscle that's contracting inwards. So the vectors of force are not, unidirectional, they're multidirectional. And again, running sutures tend to cause more webbing and other scars after the patient's healed. So aesthetically, interrupted sutures also tend to do a little better. So here's a lady who I saw during fellowship, actually. I remember she had fallen and I think it was in her garden, if I'm not mistaken. So she had a lot of dirt. Her fracture, her laceration, although it looks like it's just around the eyelid, it was a bit of a degloving all the way up, under her cheek as well. So we irrigated a lot of dirt out of that wound, I remember, with vasotracin, much more than I was expecting. And then again, we closed here, and good. So we can go to the next slide. Great, Ellie, go ahead.
Okay. So now jumping back into case number 2. So if you remember, this was a 23-year-old female who kind of fell face first off a snowmobile. And if you look at the picture here, you can see that her eyelid margin definitely looks abnormal. And there's kind of a piece that's kind of avulsed a bit downwards there. So this is definitely a case where the eyelid margin is involved. Luckily, it's kind of a bit more laterally, so the lacrimal system was uninvolved here. No canthal tendons involved and no fat prolapse here either. So this is more of a case of kind of a simple laceration, but including the lid margin this time. So perfect. So I'll just let Dr. Gale chat a bit about the margin repair.
Yeah, so lid margin repair is a little bit more technically challenging. Someone who doesn't do a lot of eyelid surgery may find this a little more challenging. But if you're in a position where you need to repair it, these are the things that you want to remember. Again, wound edges need to be freshened. And this is an anterior and posterior lamellar involvement.
Can you clarify exactly what you mean by freshening? Do you take your Westcott scissors and snip away? What are you doing?
Perfectly said, John. Yeah, exactly that. You take your Westcott scissors and snip away, hopefully in a straight line and not too jagged. But yeah, exactly. Yeah. And so when you have your posterior lamellar involvement, you want to think about closing it in 2 different layers. So you want to get that tarsus conge, which is your posterior lamella closed, and you need a higher tensile strength closure there. 5/0 silk works great. And then your anterior lamella is your skin and orbicularis, which you want closed as a separate layer. So there's a lot of different approaches, but one approach that I find works the best is getting your lash line approximated first. So patients may not notice if their meibomian glands are not perfectly in line, but they will notice if their lashes are not in line. So as you're putting your sutures through, you want a nice deep bite, and you can pass it through the meibomian gland orifices, but just keeping in mind that that lash line needs to be approximated properly. And a 5/0 silk works great. Its tensile strength is excellent, and it's soft. It doesn't have a lot of memory, so the suture falls away from the eye. And so the first thing you want to do is get that lid margin aligned with 5/0 silk. If you have a patient who you think is, not going to come back for follow-up, they're whatever, drug addict, homeless, whatever, and you think there's a problem with them coming back for suture removal, then you can use Vicryl as your second option. And as you can see here, the suture's been passed through the meibomian gland orifices, and then you can clamp it to the drape. Just if it's the lower lid, you can clamp to the top of the drape so that the traction is upwards. And if it's an upper lid laceration, you can clamp downwards. And next slide, please. So after your lid margin is approximated, then you want to get your tarsal plate reapproximated, and Vicryl works great for that. The spatulated needle is a little easier to use, we use a lot of those in strabismus surgery, so they're usually available. If it's an upper lid laceration, you definitely have to go partial thickness so that the Vicryl doesn't start irritating the cornea. If it's the lower lid, you can go full thickness without much consequence there. And if you're in a scenario where you're not sure, you could even think about putting maybe a bandage contact lens or something like that, just to be on the safe side, because the Vicryl will irritate the cornea for sure if it touches it from the upper lid. Okay, next slide. So now that we've got the lid margin reapproximated and the posterior lamella approximated, the skin closure, you can just use another few interrupted 5/0 silk sutures, and those will bring the skin into position. And ideally, if you have lid margin sutures, you want to imbricate them within some of your skin sutures, just to make sure that none of the ends start to poke the cornea. Okay, next slide. And yeah, next slide. Great. Okay, yeah.
Okay, perfect. So this is just a repair of her afterwards, so you can see eyelid put nicely back together there. Okay, so then.
Ellie, was that the case you did? Did you repair that, or?
I did a little bit, but it was mostly Patrick, the oculoplastic.
Oh, that's good. Yeah.
So huge shout out to him. But yeah, this was a case I saw on call with him. And then last case that I talked about earlier. So this one again was a 21-year-old female who was assaulted, and you can see here that the laceration is quite medial on her upper eyelid there. So in this case, the eyelid margin you can see is obviously involved, and on probing, the canaliculus was involved too. Even without probing, you probably will have a high suspicion that the canalicular system will be involved here. And no fat prolapse here and no canthal tendon involvement. So this is a case where the lacrimal system is involved, which kind of presents some unique considerations here, because you do want to intubate the lacrimal system to make sure that the canaliculus stays patent and allows for it to heal well. And then basically this slide is just to keep an eye out for any kind of canalicular system injury if the laceration is medial to the punctum. So if you see that, just have a very high suspicion that the canaliculus is involved. And
actually, I wanted to stop, Ellie. I have heard, over time, some people saying that it's okay if the upper one is lacerated. You can just leave it because the lower one will take care of things. Just want to say that that's a fallacy. Certainly, some people will drain preferentially from the lower. There's a small percentage of people that will drain from the upper, and some people drain equally through both. So you don't want to think of it that way. I think that they both do carry pretty equal importance. Sorry to interrupt, Ellie.
No, I think that was good timing because.
And could I echo in that regard, Harmeet?
Hey, Jamie.
How are you doing?
Good.
you know, the advent of monocanalicular stents lends credence to that argument to repair upper ones if you can, because you can do that without instrumenting the lower and risking damaging.
Mm-hmm.
Perfect, thank you. So again, I'll just hand it back to Dr. Gill to briefly discuss the repair of these kind of special types of lacerations as well.
Yeah, perfect. Thanks. And I totally agree with Jamie that the monocanalicular stents are something that certainly, you know, could be used if it's a more simple laceration. And if you have access to those, certainly I think it's something to think about. But generally speaking, you know, most ophthalmologists would refer these patients in terms of, you know, sending them to oculoplastics for repair. In terms of timing, it's an area of, I guess, some not controversy, but people are always talking about, you know, should we do it later or earlier? I mean, certainly this is not like a MAC on versus MAC off RD situation. It's just going to be easier or harder for the surgeon, really, you know. And Ellie is going to give you a reference to one study that said, oh, it makes no big difference if we do it within 48 hours or after 48 hours. I think, again, it'll just be harder or easier for the surgeon in one scenario or the other to find those two cut ends, because as Jamie knows, like, we could be in the OR for 10 minutes or we could be there for maybe an hour and a half. Maybe not Jamie, but I've spent a lot of time sometimes looking for these cut ends. And, you know, if you have a patient who's super swollen and there's a lot of other things going on, I'll wait till the swelling goes down. Sometimes we even give them a little bit of IV prednisone to just help the swelling get down so I could find those cut ends. But if there's not a lot of swelling, I mean, there'd be no logic in waiting for a wound to epithelialize. And then, as you know, John and I were talking about, devitalizing all those tissues again and causing trauma, and then, you know, and intubating it. But again, like everything else, it just depends on timing. You know, if you get this call on Friday night, your management may be different than if you get it on an OR day, Monday morning. We can just do it at the end of the day. So from a practical point of view, I think it's important to at least look for and try your best to know whether or not a canalicular laceration is present, because that will really affect triage. Like, I know when we get a call, that would affect my management. And, you know, what we do when the patient comes in is dilate and probe. Here you can see it's a very clean laceration. Interestingly, the more medial the laceration is, the easier it is to find the cut end, because it gets, you know, more and more dilated. So it's, I kind of like the ones that are a little more proximal. You always have to be gentle, and blunt exploration certainly is better than being aggressive and trying to, you know, spread those tissues with anything sharp. And, you know, creating a false passage certainly can happen. And that, I think, is where people who fail getting a successful intubation get into trouble, where they think they saw the opening and just were a little bit more aggressive and actually created false passages. Next slide, please. So generally speaking, if I had the option and I had the luxury of as much OR time as was available, I would always do a bicanalicular intubation. I found it looks way better because you know, in the US, for example, you can get OR time more easily. I remember we would almost always do a bicanalicular intubation, patients in the OR under general anesthetic. And if you just think about the mechanism of putting a bicanalicular tube in, you've really taken all the vectors of force and put them into the right location. And then, you know, the tension is like a suture can never create that, especially if you have any type of medial canthal tendon involvement. I found patients who unfortunately get monocanalicular stents and they have any, like, you know, the anterior limb of the medial canthal tendon involved, their lid never looks right. It always looks a little flat and low. And although they're thankful, you can tell that they kind of hate the way that they look, right? So, and they're very difficult to repair. Like, I have 2 or 3 patients I've seen over the years where after the fact, like, they're just never quite the same. And maybe, Jamie, I can just pick your brain while we have you here on the panel. Like, what do you think about that? Like, I think if you had all the OR time available, I know sometimes we have no choice, you have to do a mini Minoka, but I think a bicanalicular stent certainly gives you a better outcome functionally and aesthetically.
Yeah, I think the mini Minoka is useful where you have a single canaliculus that's cut and it's fairly lateral, because then you don't really have so much issue with the medial canthal tendon. The problem is getting into the OR, and I can tell you so much. I had one case I remember where it was very medial and we couldn't do the case with the mini Minoka. And by 4 or 5 days, we simply couldn't find it. There was nothing left to find. And there were so many orthopedic issues, traumas and things that we couldn't get into the OR. But I agree that a bicanalicular pulls everything in medially and posteriorly and is preferable if you can get into the OR.
Yeah, thanks. And we could go to the next slide. So when we do have, if we are doing a mini Minoka or a bicanalicular intubation, you still want to get sutures in front of and behind the stent itself. So again, that anterior posterior lamellar closure. Next slide. And again, timing of repair. I mean, this was a study they did, but it was pretty silly, I think. I don't think it's just sort of affects our clinical management. And next slide. Yeah, go ahead, Ali. I think this is
perfect. So coming to the end here for the eyelids. So just the last thing we didn't touch on yet was if there's fat prolapse from the upper eyelid. And Dr. Gill kind of alluded to it earlier. But in this case, when there's fat prolapse, that means that the orbital septum has been breached. So it just makes you want to have a higher suspicion of a possible orbital foreign body or some kind of deeper injury in the orbit there. And again, as we kind of mentioned, in these cases, you certainly want to try your best to irrigate the wound with lacerations solution. And if you're able to explore briefly or make sure they get a really good scan to look for an orbital foreign body there, just because your index of suspicion will be a lot higher. And if there's any very obvious or easy to repair levator lacerations, then you can go ahead and do that. But otherwise, I think the main take home, if you see the orbital fat, is that you should have a higher suspicion for orbital foreign bodies.
But make sure you're not repairing the septum thinking that it's levator.
Yeah.
Okay, so that kind of brings us to a close here for the eyelids. So again, just if you keep a simple approach and maybe have these kind of 4 considerations on your mind when you're seeing and triaging these patients. Is there fat prolapse? Is the lid margin involved? Is the lacrimal system involved? And is the canthal tendon involved? And hopefully this kind of gives everyone a basis to work off and can help make these a bit easier when you're seeing them on call.
One other comment is with the canthal tendons, remember there's a posterior component. The lids wrap around posteriorly, both medially and laterally. And if that isn't addressed, then you can end up with a localized ectropion that can look funny and be less functional. Perfect.
Thanks, Jimmy.
Here's a question for you from the audience here. So Jeremy from Hong Kong. So thank you for joining us on Friday night. Any techniques on how to find the medial opening in a canalicular injury? Pigtail or stain? Maybe that's for me.
Yeah, well, good question, Jeremy. I think it's funny, it's sort of like, if we had the cataract surgeons asking them, what do you do when you start seeing a tear? There's a lot of different tools, and you want to have as many tools as possible. I found in my hands using phenylephrine drops, just dropping it on the tissue, using cold water, in the Bassi tracing irrigation allows a lot of vasoconstriction, so the tissues don't look as engorged. Then you can find that cut end. You can actually, I like direct visualization is what I'm trying to say is my preference. I have a pigtail probe in my hands. I just don't like the way it feels. I almost feel like I'm causing more trauma because of the shape of it. But I know, some docs do well with it and they enjoy it. Or not enjoy it, but they can get the job done. I've tried injecting viscoelastic through the upper or lower to see if you can just dilate it. But I'll be honest, in my hands, direct visualization is the only thing I found worked for most of the cases. But Jamie, maybe you could speak to your experience as well.
Well, very similar. I just like to see it as well, and I just have to tell myself over and over again that medial cut end is going to end up more posterior and more medial than I think it's going to be, and then start looking in that place where initially you didn't think it was going to be, and usually can find it.
Yes. And Jeremy, one tip though is if you think about your two puncta, they're vertically totally in line with one another. So if you just physically put the lid back into where you think its anatomy should be, you can almost sort of see it a little better. It's weird, but I find that helps quite a bit, just sort of mechanically aligning the two puncta, and then you can sort of get a sense of, okay, this is where it should be, and then you can hone in on that area rather than just looking at a diffuse area of exposed tissue. Okay. Perfect. So it looks like we're going to move on to Safwan and start with the orbitofacial trauma. Oh, hey, Alan.
Hi, Harmeet. One point just to remember, the emergency room is pretty good with this, but you want to make sure that patients get their tetanus injection if they've got some sort of a foreign body. I remember when I was, a while ago, during my internship in Montreal, patient actually died from not having a tetanus injection. So I think that that's, ER is pretty good at giving it, but sometimes they fall through the cracks. So just check that. I think it's a good idea.
Absolutely. Thanks, Alan. Totally agree. That's very, very important. Yeah.
When I was in the ER doc in North Bay, there was a case not on my shift where somebody missed a tetanus shot, and the patient did get tetanus. He survived, but he was paralyzed, had to be paralyzed for treatment, and went on for several months in the ICU. And in the end, he was just upset that he missed the summer.
Oh, gosh. Yeah. Yeah. Assume nothing, right? You have to verify that all of this stuff is done. Yeah. Great. Safwan, do you have your slides ready for the orbitofacial part of our talk?
Yeah, I think so. I'm going to share my screen right now.
Yeah. So Safwan kind of got the harder topic in some ways because the orbitofacial trauma is very multidisciplinary. There's a lot of different nuances to it. So he's going to start going through that, but we won't dive too deep. A lot of it is just to give an overview at a high level, what are the considerations, and then, you know, how to triage your patients. So that's what we'll do, but we will kind of, for the resident's sake, go into some slides that may be helpful for your exams and OCAPs and stuff. So we'll have that information that you may want to review.
All right, thank you, everyone. I'm Safwan, I'm one of the BGY2s, and I will be presenting in the second half of the ground rounds today about approach to orbital trauma. And before I start, I would like to take this opportunity to thank Dr. Harmeet Gill and all the residents who have been involved in these cases for their help during this presentation. We will be discussing 3 cases, and in each case, we will be quickly highlighting one of the orbital trauma emergencies that we commonly see on call as residents. All right, so with that, our first case, a 60-year-old gentleman who have been assaulted with a broken glass bottle. As we can see in the picture here, he has an obvious lid laceration that involved the margin, as well as canicular and facial lacerations. And he also had a globe rupture in exam. And often these trauma cases need multidisciplinary approach. So what to do next? It's very important to get a high resolution CT scan, 1 millimeter cuts axial and coronal, because most of the time these patients already had like a CT scan in the emerge, but sometimes it's not the resolution that we needed. It's very important to suspect other fractures and injuries. And again, we cannot stress enough the importance of involving other teams, ED, plastic surgery, ENT, oral and maxillofacial surgery, neurosurgery, sometimes even medical teams. And finally, refer and ask for help. Now, this is just a refresher slide about the approach to examination. It's very important to be as thorough as possible in these trauma cases, starting from the vision, the intraocular pressure, and the pupils. And it's very important to assess and rule out any globe injury in any orbital trauma case, an assessment of extraocular muscle movement, and performing force action test if there is any concern about entrapment. And then the preorbital exam, it's very important to look for ecchymosis and edema, skin laceration, epiphallus or proptosis, canthal dystopia, infraorbital sensation, and palpating the orbital bones for any deformity.
Actually, I'll just stop, Safko. If you go back for a second, I would just say that with these types of trauma cases, you want to have a higher awareness that medical legally, there's a, you know, this patient may end up suing someone, and it could even be the doctor. I'll just mention that try it at all costs not to become the MRP, most responsible physician, because the level of responsibility is very high. It doesn't happen in the academic center so much, but let's say in a community hospital, you know, for whatever reason, an emerge doc felt, oh, this is I. And then they said, you're going to be the MRP. But then you missed other, you know, a small fracture in the roof and the patient was leaking CSF fluid or something else. If it's something that's an orbital fracture, I would try at all costs to avoid being the MRP unless you really enjoy this stuff and you want to dive deep in it. So that's one thing. And then because these things can become medical legal, extra cautious with your notes, write more than less. So I'll just mention that as a, I mean, we all know that, but I just want to stress that. Yeah, thanks, Saf. We can go to the next slide. So when we're thinking about, you know, the bony walls around the orbit, most fractures will happen through the thin medial wall and fracture into the sinus. The more posterior the fracture is, the more worrisome it is, the closer it's getting to the brain. And if you start hearing about, you know, the sphenoid sinus, which is quite far back, having blood in it, or it has, it's getting close to the optic canal, then certainly, you know, you have to have a higher more vigilance there. A lot of fractures are also into the, the blowout fractures into the maxilla and the maxillary bone. And so those are a little bit easier to manage. It also allows, the orbital compartment to have a little more volume if there's, bleeding or if there's any swelling. If you hear about a lateral orbital wall fracture, like a ZMC, zygomaticofacial fracture, clinically, you'll see lateral canthal dystopia, like the lateral canthus will just look like it's rotated down. Most emerge docs are sophisticated. They know like to call oral maxillofacial or plastics or ENT, whoever's taking their facial trauma call there. In Toronto, oculoplastics doesn't do facial trauma calls. So we usually, get involved after the fact, but just, as you're kind of managing these patients, it's good to be aware that, that can happen, ZMC fractures. If the orbital roof is fractured, if you hear anything about, oh, the CT showed a small fracture in the roof, I would just get neurosurgery involved. I mean, you can go through nuances of, is it, anterior table, posterior table, and so forth, but it's always better just to get them involved, that you've done your due diligence and informed them. Yeah, next slide, please. And this kind of covers what we just talked about. And next slide. And in terms of the floor fractures, a big thing is about timing of orbital floor fractures. There's a lot of studies that talk about this. We've heard this a million times, but we think about how much respective enophthalmos they have. Is it more than 2 millimeters? How much restriction do they have? And how much double vision do they have in functional gaze positions? So the indications for repair, certainly if you have an entrapment, is to do it as soon as possible. Like that's an urgent, level class B type of case. It's riskier in younger people because, those green stick fractures, if you think about a green stick, it's named after just the way a branch would fracture. It's not going to break cleanly. It's going to break partially, and then it can kind of snap back and catch a muscle. And that needs to be repaired urgently. I think Dan DeAngelis probably deals with that more. I don't think I've seen a muscle entrapment, maybe once in my career so far, so don't see them very often in adults. Certainly if you have a large fracture, if it's involving more than half the orbital floor, they have hypoglobus or enophthalmos, we're going to repair it. But that could be done later. Again, the sooner the better, though. There's no point in waiting unless you have a long OR wait list. I think otherwise it's better to get them done within a few weeks. Persistent double vision, certainly that can be an issue, but some traumas actually cause a lot of inflammation around the muscle complex. So it's not always because of the fracture. If I hear about a lot of orbital inflammation or the eye muscles inflamed, or there's any type of hemorrhage in the orbit, then I would wait to see if their double vision resolves, because you can't really guarantee the double vision will improve just by plating the floor or the wall, medial wall. In general, you might get called sometimes where they'll say, oh, they're query retrobulbar hemorrhage. That's something where they may call you like, okay, we have a patient, trauma, the eye, the vision seems to be okay, but they're query retrobulbar hemorrhage. Unfortunately, you do have to go in to see those patients right away. Sometimes the hemorrhage is not clinically significant, but it's something you have to be aware of. And then the timing we talked about, and then the wide-eyed orbital floor fracture in pediatrics. Yeah, I mean, in pediatrics, everything, you have to be a little bit more careful about everything with kids. Generally, when you're examining a patient with possible entrapment, you have to be aware of that oculocardiac reflex. So that means, if you tug on the muscle, as you know, the heart rate can drop to a point where the patient passes out. I'm not aware of anyone suffering any serious long-term consequences from it, but, if you're examining a patient, just be aware that if there's any sort of tension on the muscles, that they may have that reflex. So you want to make sure you have like a nurse with you or someone else. Thanks, Saf. You can go to the next slide.
All right, thank you, Dr. Gills. And with that, we'll come to our second case for today. A 60-year-old gentleman who had been hit by a horse. The vision in the involved eye was 20/40. He had ansecoria and traumatic races, but there was no IPD reverse. His IOP in the involved eye was 55, and the globe was confirmed intact on exam. And here's the CT scan. Dr. Gill, do you want to comment?
Yeah, so, one of the big things that Saf already mentioned is that, you may get a CT scan that's already been done. Now, certainly if a patient's like, intubated and they had major head trauma, you don't want to necessarily get like 1 millimeter cuts, axial and coronal, but you have to be aware that if they did the standard scan, it may be cuts that don't capture all of the information you need. looking at like, optic nerve impingement, for example, from an optic canal fracture and so forth. But, generally an axial scan will show you what's happening with the medial wall and the lateral wall. So if you look at this scan, I don't have a pointer here, but you'll see like the medial wall certainly has fractures into the ethmoid sinuses. The posterior sphenoid sinus seems to be clear, but if that was also filled with blood, then we'd really be worried about a traumatic optic neuropathy. A lot of studies have showed that they're highly correlated. And then if you look on the lateral wall there, you can see there's a little rotation of the zygoma. So that's a small ZMC fracture, which may or may not need to be repaired. So you want to think, your axial scans will show you the medial and lateral walls, and then your coronal scans will show you the roof and the floor. I think it's fun, obviously, to look at these, but if you don't look at a lot of them, you want to get on the phone with a radiologist while you're on call, and maybe even while you're driving to the hospital to see the patient and see how much information you can get, so like sort of which other services you may need to get involved. Yeah, next slide.
So with that would come our next orbital emergency, orbital compartment syndrome, which should be suspected in any case of trauma and high intraocular pressure. Other clues in the exam can include RAPD, decreased vision, tight eyelids, or restriction of extraocular muscle movement, proptosis. And it's very important to stress that it's a clinical diagnosis, but we usually obtain CT for confirmation, and the treatment is with urgent lateral confotamen canthalisis. And again, there is a risk for rapid and permanent vision loss. So if the clinical suspicion is strong, sometimes confotamen canthalisis can be performed even without getting a CT.
Yeah, with orbital compartment syndrome, if you have hemorrhage in the orbit, it's a problem. But when you start noting, when the radiologist says there's tenting of the posterior sclera or the optic nerve is on stretch, that's very dangerous. So that's sort of something you should also be aware of. And we can go to the next slide, Saf. When you're doing a canthotomy and canthalysis, if there's some bleeding that's continuing, if you just do the canthotomy and canthalysis, you may actually cause more problems, where if the bleeding continues, it may start putting even more pressure and on the optic nerve. And so I always say that when you do it, be ready to like put pressure, just tamponade, like push down on the globe. And even if it feels rock hard, sometimes you just have to hold it down and then maybe call for help in the sense, like in the academic centers, we have residents and fellows that can help us. But, if you're really stuck in that situation, you may even need to get maybe ENT involved to help decompress the orbit if it's like a vision-threatening problem. Certainly when you're doing a canthotomy, canthalysis, you numb the area, and one practical things that I'll say is people sometimes think that they have to release at the orbit, like you have to dive your scissors back quite posteriorly. You don't need to do that at all. You just need to go, if you hold the lid a little bit away from the eye, just release the tendril attachments, because what you're releasing really is the eyelids. Like you're not doing anything orbital at all. The lateral canthus, we all learned that it connects at Whitnall's tubercle, but you're not trying to disinsert the lids at Whitnall's tubercle. You just need to get those eyelids off, and it'll save a lot of problems. Otherwise, if you try to go deep, you may end up causing more bleeding and other problems. Yeah. So, and if you're doing the canthotomy canthalysis, you might as well do the lower and the upper. And again, just be ready to hold pressure on the globe if you need to. Okay, next slide.
The only comment there is that if the orbit's still tense after you've done that, then perhaps you haven't done enough. And in that case, my preference is I take a curved Stephen scissors and go down the inside of the lateral orbital wall and then spread it. I don't cut, I just spread and come out.
Perfect, yeah.
All right, back to our case. This patient had a lateral canthotomy canthalysis, inferior canthalysis urgently performed. The IOP fell down to 30, so superior canthalysis was also done, and the IOP fell to 20. The orbital fractures repaired by plastic surgery a few days after, and the IOP remained normal, and the vision went back to baseline. Just by the end of this case, I just would like to say how fortunate we are as residents to rotate through Sunnybrook rotation and have exposure to this vision-saving procedure. All right, and then our third case and last case is a 65-year-old gentleman who suffered a multi-system trauma after falling from ladder. He had significant preorbital edema, ecchymosis, and bilateral orbital floor fractures. His vision in the right eye was 20/40, and the left eye was counting finger. Very importantly, he was noted to have a left RAPD, and the IOP was 14, and the remainder of the exam were unremarkable. And the CT scan, Dr. Do you want to comment on the CT scan?
Sure. Yeah, so Seth, thanks. And so again, you can see the CT scan was not the highest quality, most likely, but it certainly shows the fracture. If we're looking at the posterior orbit there, it looks congested. And like one of the things you may encounter is where they're not sure if the optic nerve is impinged, if there's a bone that's fractured. Now, that's not something orbital surgery necessarily does alone. We would, neurosurgery could do it on their own through a craniotomy approach. I personally have never been involved in a case where we had to take a bone fragment off the optic nerve, but it's something to think about. And again, you can see sort of that opaque sphenoid sinus is completely opaque there, filled with blood. So usually the visual prognosis in these patients is bad, whether it's direct or indirect traumatic optic neuropathy. So it tends not to be as good. Yeah, go ahead, Sam.
So our patient had a trauma and reduced vision and RAPD, so it's very important to look out for traumatic optic neuropathy. We elected to treat this gentleman with 3 days of 1 gram IV methylprednisone, and the vision improved from counting finger to 20/40, and the RAPD resolved. The first day of the steroid, the patient complained of deteriorating vision, and the vision was counting finger and had an RAPD. We discussed with other teams plastic surgery and neurosurgery, surgical treatment options, but given the improvement in vision and steroids, so the patient was resumed an IV steroid for 2 additional days. The vision again improved to 20/40, and he was maintained an oral steroid tipper, and the vision remained stable on follow-up exam. So traumatic. Sure.
Mm-hmm. No, I was just going to say, so this would be the exception. We're really happy. That patient did better than most do. It was more inflammation around the optic canal that was responsible for his vision loss. So the high-dose IV steroids helped. With head trauma in general, there are some contraindications based on some big multi-center studies, which Saf will review. But as long as the other teams are okay with giving high-dose IV steroids, that's basically all we can do for these patients. And luckily, this gentleman really did well, but he's sort of more the exception to the rule. Thanks. Yeah.
So for traumatic optic neuropathy, it's an acute injury to the optic nerves that can happen either directly or most commonly indirectly. Usually it's indirectly through transmitted forces from blunt orbital trauma, and directly it can happen through optical canal fractures or bony fragments around the optic nerve. So the treatment with high-dose steroid, as Dr. Gill already alluded to, is controversial. The National Acute Spinal Cord Injury Study showed that treatment with high-dose corticosteroid actually improved neurological function. However, the CRASH study showed that high-dose corticosteroid actually increased the risk of death in severe head trauma. The International Optic Nerve Trauma Study showed no benefit of high-dose corticosteroid or even optical canal decompression in the treatment of traumatic optic neuropathy.
Yeah, so with a lot of these studies, it's all about timing, as you can guess. I don't know how I mean, this is the best that we have to go with, but really it's about timing, as we know, with in terms of trying to preserve vision. So, but the take-home message is that if there's head trauma involved, you need to get sort of permission before you give high-dose IV steroids. And otherwise, if the medical team and the neurosurgical team is happy, then might as well give them like 1 gram of solumedrol. It can be vision saving, but you have to do it quickly.
All right, and now just finishing up with intraorbital foreign bodies. So CT is usually preferred over MRI for orbital foreign bodies for very obvious reasons. And the management is usually based on the composition and the size and the location of the orbital foreign body. And as Dr. Slomovic already alluded to, it's very important to not to forget to treat with anti-tetanus prophylaxis and broad-spectrum antibiotics in any case of intraorbital foreign body. So the composition matters. So organic foreign bodies usually can cause significant inflammation and infection, so should be attempted to be removed. Also, some metallic foreign body can cause some specific complications such as retinopathies or systemic toxicity. Also, the size matter. As expected, small fragments usually can be left in place and monitored. Large foreign bodies can cause several complications such as traumatic RDs and optic neuropathy. And the location also affects the management. So anterior orbital foreign body usually easily accessible surgically, so it can be removed. A posterior orbital foreign body are more likely to cause complications. However, there is high risk surgery. So sometimes in special cases, in absence of complications, these foreign bodies can be monitored. Then just to take-home message, approach, be as thorough as possible, and look for the clinical and radiological signs. And the imaging, again, as Dr. Gill already alluded to several times, get high resolution CT scan because the standard CT scan sometimes can miss some fractures. Involve and collaborate with other teams and refer and ask for help. Thank you so much. We'll be happy to receive any questions.
Perfect. Thanks, Saf.
Harmeet, so a couple of years ago, we had a rounds about the steroids for traumatic optic neuropathy, and I left with the impression that I should not bother with that anymore. But here you're suggesting that within a certain time frame, and if it's acceptable from the standpoint of other injuries and other services, that it perhaps still has a role if given in a certain time frame. What is that time frame? Can you give us more information on that?
For sure, John. It's such an important thing. I think a lot of people feel because the prognosis is so poor that why expose a patient to additional risk? But honestly, like if it was one of us or our family members, I would, with a heartbeat, do it. Like, you know, we can manage blood sugars, but you only have that window of time to get that inflammation down. So this case, although it's not the norm, like, you know, a lot of patients would continue to have poor vision. Like we could see went from, you know, counting fingers to 20/40. We withheld steroids for a day, went down again, RAPD, gave them steroids again. So you do need to, I think it's, you know, I would definitely do it to be like take home message. If a patient is in this situation and there's no impingement, like there's no mechanical, like one of the things we weren't sure of is the bone actually causing the problem, in which case you can just work with neurosurgery to get the bone off. But if it's just inflammation at the orbital apex from a fracture, I would definitely always give a high dose IV steroids. As a general rule, 4.5 grams total, like the cumulative dose of 4.5 grams is something to keep in mind, because after that point is where you get into hepatotoxicity. So if you're going to do this, work with the medicine team, just make sure they're getting a baseline liver function and you know, blood sugars, of course, but blood sugars are not the end of the world. Like they can manage those with drugs, but hepatotoxicity may be something where you could get into trouble where, you know, because at the end of the day, medical legally, you don't want it to be where, you know, a patient ends up with liver failure and their vision is still, you know, counting fingers and they try to sue you or something. So I think it's honest. It's good to have an honest discussion. I document all of this stuff in detail, but, you know, long story short, John, I definitely would use IV steroids because there's nothing else, you know.
And within what time frame? 12 hours?
I would do it as soon as possible. Like I usually tell them stat, yeah. But I think your question may be, well, what if 48 hours has elapsed? What if 72 hours has elapsed? Is it worth doing? I would still do it, looking for an improvement. Like I wouldn't do it a week later, but within the 72 hours for sure.
There was a question from the audience about anticoagulation, and it says that the residents are often called, what's the guideline for anticoagulants in orbital fracture and hemorrhage? They're asked by the trauma team if it's safe to resume anticoagulants or antiplatelets following these injuries.
Yeah, you know, Shaibo, it's a good question. I think it's always it's always weighing the pros and cons, and I hate to frame it this way, but you have to think about the medical legal things, the consequences of your decision, right? So I would make this decision in collaboration with the team, like how important, what's his risk of bleeding or stroke or whatever the patient's, like if they're getting anticoagulants for a heart arrhythmia, I would rather say, okay, monitor his EKG daily, but hold off on it in, you know, for at least 72 hours, 3 days, where the risk of rebleeds are higher. But at the end of the day, I mean, they're lying in a bed at this point, their heart rate, their blood pressure is not very high. So there's a lot of nuances to it. The risk of rebleed would be higher in a person who's like very hypertensive and has other, you know, vasculopathies and so forth. But if, so I don't know if I'm answering your question. The point is I would try to document what is the actual risk of not starting it. And then we weigh that against what's the risk of a rebleed. If the risk of a rebleed is high, I've never seen a patient rebleed, whether we started anticoagulation or not, but it doesn't mean it can't happen. I think, again, in orbital surgery, the patients, you know, when they're getting up from anesthesia, their heart rate's going up, a labile blood pressure would probably be the highest risk. And in that case, if we do have to restart it, medical legally, what you need to do then is reassess the patient in 12 hours and 24 hours, or in our case, ask our lovely residents to do that. You know, we can maybe do it more frequently because it's so convenient. I'm just kidding, but Shaibo, yeah, I think that's sort of the big thing. And I'll just maybe, I know we're done with rounds, but maybe Jamie, you have so much experience at St. Mike's. What are your thoughts about it?
Well, basically, I would echo what you said. You're sort of between a rock and a hard place. And I think I have probably seen some rebleeds, and I've also seen people suffer the consequences of not being on their anticoagulant. So like you say, you just have to balance things.
Mhm.
I would say as far as the steroids go, I'm a little more in the negative camp because of the results of the optic nerve trauma study. But in the case you presented, it clearly helped because you did a withdrawal test.
Mhm. Thanks.
Harmeet, those are excellent rounds. Couple more questions for you from Jeremy. This relates back to the previous talk. Any special considerations for a bicanalicular injury?
Oh yeah, bicanalicular for sure. You're going to use a bicanalicular stent, but the principles would be generally the same. You know, find the cut end of both the upper and the lower. And again, you know, Jeremy, like I just want to reiterate when people say like, oh, the upper is lacerated, but you don't have to repair it. I feel strongly that you don't want to do that. So for bicanalicular, it's a no-brainer. They're going to the main OR and they're going to get a bicanalicular intubation. And I think you also asked Jeremy about using proline to intubate. That's very creative. I've never done that myself, but you know, anything you can do to cannulate and get a continuous epithelial line track would be good, but I'm not aware of that, but it seems like a good idea to me. I don't know, Jamie, if you've ever used proline for intubation in your lacrimal cases?
No, I like the bicanalicular tubes with the little olive tips so that you can use a Crawford hook.
Perfect.
In terms of technique, though, what I like to do, besides sewing the tendon around the canaliculus, I like to take a double arm sevenochromic and place it from inside to out. So it's actually through the wall of the canaliculus. Ideally, one would do 3. I only usually do 2, the ones that you can see. You can't do the posterior wall. And you don't tie it until you've tied the other ones that take the tension off and then put it down. I don't know if it makes any difference. But.
Great idea.
All right, I'll hand it over to John.
Again, thank you very much, Dr. Gill, and both Ellie and Safwan for your excellent presentations. Great rounds. And next week, we're combining our rounds with Jack Crawford Day. Look forward to seeing you all then.
And we have a cataract course tomorrow.
Oh,
you're not signed up.
Yeah. Cataract course tomorrow morning, 10 a.m., right?
Here.
Yeah.
8 a.m. in Costa Rica.
Have a good day, everyone.
Great rounds. Thank you.
Thanks. Bye. Bye, Sri.